In the present talk, I'm going to focus on a non-invasive technique, the heart-trans heart rate variability algorithm for the detection of myocardial ischemia. Currently, non-invasive detection of myocardial ischemia requires imaging modalities that are associated with multiple complexities, including a relatively low sensitivity and specificity associated with exercise stress testing, radiation exposure associated with myocardial perfusion imaging and CT angiography, and relatively high costs associated with most current non-invasive imaging modalities. In contrast, heart rate variability analysis is a non-invasive and relatively inexpensive test which does not expose the patient to ionizing radiation. The test has been shown to correlate very well with all-cause mortality, cardiovascular, and specifically sudden cardiac death. Furthermore, limited prior data suggests that heart rate variability may be possibly used for the early detection of myocardial ischemia. Accordingly, the heart-trans novel heart rate variability algorithm was developed by Professor Levitan at the University of Triel, together with Level, for the purpose of non-invasive detection of myocardial ischemia using a very simple 1-hour Holter recording. Based on pilot data, we hypothesized that the heart rate algorithm is superior to conventional exercise testing for the detection of myocardial ischemia, and accordingly, we carried out a prospective multicenter study designed to validate the diagnostic performance of this test for the detection of myocardial ischemia in patients without previously diagnosed coronary artery disease. As mentioned, this was a prospective multicenter clinical trial. We enrolled 378 patients. The inclusion criteria were age that was equal to or greater than 21 years, referral for exercise myocardial perfusion imaging by the treating physician, and willing and able to provide written informed consent. The design of the study was as follows. All patients underwent 1-hour digital Holter recording together with exercise stress testing and myocardial perfusion imaging test, and following that, heart rate variability analysis was assessed using the heart-trans device. Following completion of those tests, comparisons was made between the sensitivity of conventional exercise stress testing with the sensitivity of the novel heart-trans heart rate variability algorithm for the detection of myocardial ischemia using a positive MPI myocardial perfusion imaging testing as the endpoint. The test was defined as follows. A positive exercise test was defined according to current guidelines using equal to or greater than 1 millimeter ST segment depression or elevation, or evidence of ischemia, clinical electrocardiographic, together with blood pressure drop during effort. The heart-trans analyzes the hour wave intervals data based on the specific algorithm, and the output received is a score called the DYDX indicator value. And a DYDX indicator value, which is less than 2, is considered to be positive. And finally, a positive MPI was defined as the presence of greater than 5% reversible myocardial perfusion defect using SPECT MPI. The parameters that were assessed and compared between heart rate variability and the heart rate variability and the conventional exercise stress testing included sensitivity, specificity, positive and negative predictive values, with comparative analysis between EST and the HRV for the endpoint of a positive MPI. When we look at the clinical characteristics of the patients, we see that this was a relatively intermediate risk cohort. With a mean age of 61, 35% of the patients were greater than 65 years of age, 63% were males, more than 50% of the population had hypertension and dyslipidemia, 1/4 had diabetes mellitus, with a BMI of 29 and a positive MPI detected in 50% of study patients. When you look at the diagnostic yield of the two tests, we see that the HRV analysis, the new heart rate variability algorithm, was associated with a high sensitivity of 79% compared with only 29% associated with conventional exercise stress testing. In addition, the new heart rate variability algorithm, the HeartTrend device, was associated with a specificity of 71% and a negative predictive value of 98%. In multivariate analysis, we see that a positive heart rate variability algorithm was associated with nearly 8-fold increase likelihood for the detection of coronary artery disease that was statistically significant, as compared with only 2.4-fold increase likelihood for the detection of coronary artery disease associated with conventional exercise stress testing that only approached statistical significance. And this was associated with a relative incremental value of nearly 5-fold for the heart rate variability heart rate algorithm compared with conventional exercise stress testing. So in conclusion, our data indicate that the novel heart rate algorithm device shows a high sensitivity and negative predictive value for the detection of myocardial ischemia in patients without known coronary artery disease, and that the sensitivity and relative incremental value of this test is significantly higher than conventional exercise stress testing. And these findings suggest that the heart rate algorithm can be used as a simple screening modality for the detection and early detection of coronary artery disease. Thank you.
Thank you very much for the excellent presentation. So, given that we have so many choices now with screening tests, where would you see the role of this type of technology in the routine evaluation of outpatients in the clinical practice?
I would see this test is verified. We're currently conducting multiple clinical trials both in the US, Europe, and Japan. Following confirmation of these very positive results, I think that in the future, this can replace exercise stress testing that, as I showed, that's a very low sensitivity for the non-invasive detection of coronary artery disease.